Tracy, yes, Tracy. No, I was thinking Crystal. Tracy. That's the one I'm going, no.
That's what I have.
Anyways, Tracy,
I don't even want to touch on this subject.
Did you know Crystal? Oh, yeah. If Crystal comes back?
Oh yeah. She used to come to our international meetings.
That's why as soon as I hear it.
I thank God she's not part of this group anymore. I can't figure that situation ASAP.
Does that say?
Away from the speaker.
No.
My blood boils when I hear her name.
Okay. That's a 32, and that's 42. That was last year's thing. They didn't correct it. Okay. That's the only change. Actually, I want one too.
I've gotten into the politics of putting things up. Apparently, if it doesn't have in VGH the thing that says it comes from Providence Healthcare or Vancouver Coastal Health, they won't. So if your doctor refuses, ask if they can put it up in the personal space, and that's why it's not up at the Diamond Center.
You mean Diamond Center?
The Diamond Center in VGH is where I work. I tried to put up food posters, and it was roundly now, and because it didn't have the little thing that said that they.
There's that part.
Yeah, and we can put it up in our private offices, but try, it's worth it. If you do have a family doctor who says nip, then it may not be that they're not, it's not because they don't want to be supportive, it's because they've been told.
Really?
Yeah.
So how come they don't produce them with a stamp?
Hey,
A little
I
white
tried.
powder, and then you stamp it?
I actually, for one of the ones that I wanted up, I cut out a little piece.
There you go.
That didn't go over.
By the way, when you guys take these posters, and I am going to say thank you, Noah. He helped us, me, create. This poster has a backing that you peel and you put on a wall. And when you want to take it off the wall, you can put the backing back on, or you can move it to another spot, and it will not affect your paint on the wall. Yeah.
Excellent.
Yeah, absolutely. Put them everywhere. Okay, so we're going to get started. So I'm going to come over here with you, Lori. There we are. Lori is RN case manager for Dr.
Shirini's at?
the University Health Network from Toronto General Hospital and Princess Margaret Hospital, Toronto, Ontario, Canada. She works in endocrinology for 32 years and in endocrine oncology for 14 years. She is a coordinator for clinical trials for growth hormone deficiency, HIV, AIDS, that
affect wasting for growth hormone deficiency acromegaly. She's a member of the College of Nurses of Ontario, Ontario Nurses Association, and founding member of the Canadian Nurses Acromegaly Association. Presented at national and international HIV, AIDS, and endocrine meetings. Thank you for coming.
So if we have time today, I'll give you a little case presentation of a brand new patient. So as Dana says, I work at Toronto General and Princess Margaret. So acromegaly patients across Canada. I'm going to give you, when Paula Van Nostrand was here last year, she's one of my patients, she said that you guys were really interested in statistics and in signs and symptoms of disease. So like the iceberg, you only see the top part of the iceberg. You don't see everything that's down below. And when you actually look at my signs and symptoms sheet, you'll see, when I'm talking about signs and symptoms, why for some patients it takes 10 to 20 years before you get a diagnosis. I was in Berlin and Boulogne-Billancourt, which is outside of Paris this year, in Amsterdam. And one of the things we've discovered in our worldwide nursing meetings is most of the patients fall in that bottom category. You see an endocrinologist for diabetes, you see a rheumatologist for arthritis, you see an ophthalmologist because your vision's changing and you keep getting your glasses changed 3 times a year. So you sort of keep going round and round and round and never getting above the water. As of yesterday, I think I was up to 729 patients across Canada. No.
So add about 200 of that.
Okay. Because Michelle Johnson had trained in Toronto, and Dr. Udier used to work with Lisa Trumbull in Halifax, so those numbers I don't have. So as you can see, this is a patient, this is a person's normal size hand, and an imprint, I think it was an Irish giant, is the stone figurine below. So these are some of our numbers from across Canada that I know about. These are physicians that I've worked with, done trials with, and meet in my meetings across Canada and around the world. So right now I have 193 active patients. Between 1991, when I first started working with Dr. Izat, to 2000, we probably had 300 to 400 patients, and of which only 193 are still carried on with us. Either they have moved to out of city, out of province. I see patients from Vancouver to Newfoundland. My friend Claire in Montreal, she sees approximately 150, and again, she probably had closer to 300 when Dr. Seri started his practice. Dr. Van Nom in London, Ontario, he works with 5 different, Stanley, I think, works with a couple of physicians, so there's 40 to 60. In Hamilton, Ali was one of our former endocrine fellows, and in his office, there's 5 of physicians. They see between 40 and 80 patients per year. Lisa and Dr. Imran in Halifax sees 81. Nandira Hassan in Cambridge sees 5 to 8. Most of her other patients have all been referred to Toronto. And Dr. Susan George, who's another endocrinologist at our hospital, sees 10 to 12. Kathy Murray. Kathy was an endocrine fellow of ours. She just got married, and now she's on mat leave this year. So she's now seeing 10. Monique is seeing 4 to 5 patients. St. Mike's and Sunnybrook I don't have information on, nor the other sites yet. So, as Deanna said, I travel the world. So I'll give you 3 different years, 2013, 14, and 15. All the information is in my package that I've photocopied for you. These are country perspectives from 2013. So out of 512 patients and 24 different centers in Italy, 40% were Italian acromegalics with an increased prevalence in their highly populated areas. So most acromegalics in Italy moved to the larger treatment centers, either by choice or because there just isn't something in their little small rural towns in Italy. Their average age of diagnosis is 45. My youngest in our practice, male, he was 15, diagnosed at the hospital for sick children, and because he's already a giant, he had a second surgery with us at the age of 18. And my youngest female, she was 18 when she was diagnosed. Most of these tumors, the macroadenomas, there's 70% of them versus a microadenoma. 16% of these patients in Italy were diabetic. 33% had hypertension, and 30% were prolactinomas. Germany's registry began in 2009, and they captured between 11 and 29 different centers. Most of them are in their university hospitals, 57% of the patients. The general practitioners only see about 20%, and there's 250 patients currently in their program. The big difference between Europe and Canada is the treatment lines of therapy. In Europe, their first line of treatment is always surgery, if they can do it. Whereas in Canada, it varies province to province and practitioner to practitioner. In our therapy centers, we start people on medical therapy first, whether it be the injectable and oral medication. Halifax and all of the eastern Atlantic provinces, they usually start surgery first. Then in Germany, their second line of therapy would be obviously the medications. United Kingdom at this time, back in 2013, a control of growth hormone, it was less than or equal to 2 micrograms per liter. Now in Canada, it's 0.4 micrograms per liter. When I first started doing testing, I think it was 5. Transfemoidal surgery, the microscopic transfemoidal surgery accounted for 40% of a cure rate, which is not great numbers. Their angled endoscopy surgeries, when they started doing those, had an 80% cure rate. And obviously, the bigger testing centers usually have better surgeons who do more surgeries, and that's what you want. If you go to a small center, they're only going to get a small portion of the somatotropin tumor. If you go to a larger treatment center who does the surgery frequently, they're going to get a higher success rate, higher cure rate, and more of the actual tumor itself taken out. And again, they use the different medications. So our 5th annual European meeting was in Lisbon, and Dr. Izat presented at that one. So again, I'll give you the different country perspectives. Portugal in 2013 had 4.1 cases per million, or 42 cases, and in 2014, 2.9 cases per million. So the difference between incidence is how many new cases you see a year, and prevalence, how many cases you see over your total practice for the year. Their age of diagnosis is 46, so it's typical to the other countries. Macroadenoma is the same at 70%, and the cavernous sinus invasion is 50%. And again, their first-line therapies are surgery, and they only get a 50% control rate, and then they're started on medical therapy after that. There's an increased prevalence of acromegaly disease in Messina, Italy. They have 97 cases, and in Liege, Belgium, there's 125 cases. Both are in highly polluted areas, and they also have an increased cancer risk in those areas. And in Liege, the incidence is 1 in 5,000 people, with 3 villages totaling 72,000. Therefore, they've got a 1 in 1,000 prevalence. These are 2 French brothers. So I'm going to talk later on about AIP mutations. So it has to do with families. And at the bottom, you can see mother and father, and then all their brothers and sisters. FIPA is a autosomal dominant disease. So we're looking at germline mutations, which we're now doing more research on. And AIP, which is the receptor, currently Canada doesn't pay for the test. If you want it done, the blood samples are sent to England or to Italy to be processed. And Health Canada or any of our provincial governments won't test it. It's probably between $500 and $600 per test, minimum. This is an article on the predisposition of the germline mutations. And right now, Ireland has 4 families they've been testing throughout the history. So you'll start with parents and grandparents and great-grandparents, and they go all the way through brothers, sisters, aunts, uncles, everybody. And there's a large percentage of giants in Ireland, as well as in Italy. There's 6 families that they're currently studying. So there had 1,500 pituitary adenomas from these AIP families, so 15 families and 30 cases. In 2006, it was up to 64 families, and 66 of them were prolactinomas. Now, many of our acromegalics have dual tumors, usually the somatotropin, which is the acromegalic tumor, and probably about the same percentage, or maybe a little higher, 50% maybe, of also have a prolactinoma. So that's why when we're looking at medical therapies, one therapy may not work. And I come from a chemotherapy background, so when we're giving medications, we just don't give one drug. We usually give combinations of therapy to try and drive that growth hormone and IGF-1 levels down. In this, there were 122 cases across 6 generations, and the younger patients usually had larger tumors, and they were germline tumors. And the larger the tumor in the younger patient, the better the cure rate. If you're not being diagnosed until your 50s, 60s, and 70s, the chances of getting the bulk of that tumor decrease over time. So then they do something called debulking, where they take out portions of the tumor, because in that case, it's probably surrounding your optic chiasm or surrounding your carotid arteries. So again, they don't want to cause any problems. In Poland, again, it's 4th and 5th decade of life. Women are usually diagnosed earlier than men, and their age of onset, they've usually had the symptoms for 5 to 10 years. Their first line of therapy, again, is transphenoidal, and they usually do about 200 cases per year. And in some instances, in 150 cases, they put them on therapy for 3 months from macroadenomas and 6 months from microadenomas. Yes, sir?
Why is the maximum dosage of the octreotide only 30 milligrams?
Each country sets their own maximum dosage. In Canada, it's 30 milligrams, both for octreotide and for pegvismant, or it's also called somatrope, because that's what Health Canada's ruled they can only use. We do have one patient on 40 milligrams of Somavert in New Brunswick, and she's done quite well.
Okay, so you don't know what their rationale is. They just sort of like, because is it more expensive to pay for the 40 milligrams? Is that what
It is.
Okay, so it's money.
It's, yeah, a lot of it boils down to money. Yeah. And each province, again, there's difficulty in getting it provincial-wide. Ontario and Quebec, because we use quite a lot of these drugs, it's easier. Our access programs, we have easier access to get it. I know in British Columbia, you've had problems in getting medications, whereas in British Columbia, a lot of your medications are covered by the Canadian Cancer Society. In Ontario, they won't. Not even all cancer drugs are covered in Ontario. Again, their first and second lines are surgery first, and then in medications in the second. And in their case, pegvismant or Somavert, as it's known here, they're only allowed to use it in hospitals. Again, because of the cost. Where in our province, I teach the patients how to give the injections at home. I send you home with all the information, the instructions. I teach you how to give your first doses, and then I arrange to access programs to get your follow-up medications and treatment and supplies sent directly to the patient's home. All of the drugs are, except for the oral medications. Now, Canada. So between 1980 and 1994, we had 169 patients. 94 to 2014, we had 470, and as I said, so far, so if we include British Columbia, we're looking at probably close to 1,000 cases. So Canada, all across Canada, represents a small European country, the equivalent of it. I mean, you could put several European countries together and still wouldn't amount to the same number of patients we have here in Canada. Small tumors do well. Large invasive tumors do poorly. The general practitioners' referral rates are 28%. From other endocrinologists, there's 24%, which, as Jerry was talking about the diabetes, they'll be seeing an endocrinologist for diabetes and not recognize that the patient's acromegalic. It's usually other healthcare professionals we get our referrals from. Ophthalmologist, I had one respirologist who was looking after, in this case, he was an identical twin. One had the disease, one didn't. His sleep apnea spells were 100 times per hour that he had stopped breathing. So he had a large invasive tumor. Yes.
I just wanted to mention, I thought it was interesting that for my son, who'd seen lots of medical professionals, his was picked up by an optometrist. So not legitimately like a medical kind of doctor, but like at the eyeglass store at the mall.
Yeah.
Just off the cuff.
Yeah.
And, you know, it was just kind of, it hadn't been even seen by anybody, so.
I've had patients come in and I'll say, well, how long have you been acromegalic? And they'll say, how do you know what I have? Because I've been working with this for like 30 plus years. I can recognize an acromegalic even after a few years, particularly when we like to have them bring in pictures in 5-year increments. And Dr. Izek can probably tell you exactly which year your disease started. Neurosurgeons, we get 18%. Dentists, 2.5, although that's increasing. We are seeing more because you'll see the shape in the jaw changed, the gaps between your teeth have changed, your bite has changed. So when I went for my checkup this year with my dentist, I said, do you see any acromegalics? And he said, what's that? I said, well, they've got too much growth hormone. And sort of the light bulb went on. And I said, do you see people who are injecting growth hormone? And he said, yeah. I said, do you see people who are injecting growth hormone illegally? And of course, like the eyes lit up, the hands started moving. And it's like, okay, so where do they get their illegal growth hormone from? The States and China. I said, are you seeing any changes? He said, oh yeah, their jaws are changing. They've got really bad gum disease, gingivitis. Their teeth are falling out. Their teeth are getting rotten. Their bite is changing. And I said, so have you mentioned to them about this growth hormone? And he said, well, I've tried, but it just sort of goes right over their head. And I see a lot of growth, in our practice, we also see a lot of growth hormone deficient patients, whether they're coming from sick kids as children that were growth hormone deficient, or as adults who've had brain injuries and things. And they're very closely monitored with blood work throughout the year to make sure that they're not becoming acromegalic, where these illegal patients that are getting their drugs off of the computer, no one's monitoring them. We get referrals from sports medicine people who've put them on growth hormone. And then I wonder why they're suddenly acromegalic. Well, because they're giving like 15 milligrams of growth hormone a day. When that's such an extremely high dose, I'm surprised they haven't had their arms and their hands falling off. Because the joint pains are so bad.
So I have a question. This has always been in the back of my mind for many years. Children with dwarfism give growth hormones, and if they can end up having acromegaly when they become adults because of the growth hormones.
We see a family currently with von Hippel-Lindau syndrome. They're primarily from Portugal. And in their case, they were all intermarried. And out of 5 kids, 2 of them have dwarfism. And we were really worried that one of them got married. Her husband's like 6 feet and she's, I don't even think she reaches 3 feet. She just had a baby a year ago and her baby's normal. So they can have normally developed children, but the potential is, again, if they're given too much growth hormone, in this case because they lived in Portugal at the time, they didn't get any. But when you look at the features of the facial features of a dwarf are quite similar to an acromegalic.
I had read a study on how children with dwarfism, they get growth till they're adults, and then afterwards they end up with acromegaly. And is that because they've been getting growth hormones all their life?
Or it could be genetic predisposition.
So, there are, so in your previous slideshow, there are 470 patients diagnosed with acromegaly in Canada.
That was up to 2014.
Okay, but I thought you said there were 1,000.
As of this year, from my statistics that I've collected already, and that's not hitting every endocrine center, we're already probably approaching the 1,000 mark.
That's a really big gap.
Mm-hmm.
And where is the statistics taken from?
These are from our own Canadian patients in our own practice.
Oh, your own practice.
Yeah.
Okay.
Yeah, and the practices from the first two slides that I showed you at the beginning. Yeah, yeah.
So would you say there has been an increase in?
I wouldn't say there's an increase. I'd say there's a better diagnosis going on because we are, Dr. Isa and myself and the other endocrinologists that do these studies, we go across Canada and around the world to lecture, and more facilities are actually posting things in dentist's office, for example. Belgium does an acromegalic day where they actually go out on the street and they'll have posters presented like at the bus stops. Brazil does another day where, again, they present posters at the bus stops and there'll be people out on the street saying, do any of these signs and symptoms, and they'll have some common ones listed up there, look familiar to you. In France, they typically say they can diagnose a patient within 5 to 6 years of their first signs and symptoms.
A lot of people don't get diagnosed and actually die. And there's a higher percentage of that than there is of being diagnosed. So things are starting to change, which is really nice.
Dr. Izat's wife, Dr. Asa, was our director of pathology and laboratory medicine, and 25% of all pituitary adenomas aren't picked up until death when they do an autopsy. The main symptoms that we see are diabetes, hypertension, sleep apnea, and cancers, and I'll explain that a little bit early. 97.6% of our neurosurgery is done for debulking, again, because the tumors are so massive. I know one surgeon we saw in France last year, he had a case of a young guy, his tumor, pituitary, cavernous sinus involvement, and you could actually see it coming down inside his nose. His tumor was so huge. Yeah. Yeah. Patients, when we're doing their testing, we like to know whether, when they get our pathology back, are they sparsely granulated tumors or densely granulated? Because the different medications work on different. So some of it works better on sparsely granulated tumors. The sandostatins and lanreotide work better on the densely granulated tumors. So from this year's conference, I've just come back from Istanbul. So that's the Blue Mosque. And they said, oh, it's going to be 22 to 23 degrees. Yeah, right. That's at 8 o'clock in the morning. It was more like 30 to 40 by the time the middle of the day. I just came back. No, next week I'm in Paris, France. Okay, so Turkey. They don't have an acromegalic registry. Their incidence is 3 to 4 per million patients per year, whereas in Iceland they have 7.7 per million per year. Their prevalence is 37 to 70 per million per year. So that 2013 to 2015, yeah, most of Europe is anywhere between 40 to 70 new patients per year are being diagnosed. Their peak incidence, again, it's middle age for diagnosis. More women are diagnosed than men. And delay in diagnosis, I'd still say it's a worldwide problem. Surgeons, the physician presenting actually admitted that their surgery techniques are not great in Turkey and that they don't have very good surgeons. So it's not uncommon for a patient to be referred outside to get a surgery done. Medical therapy, they usually start with a dopamine agonist. Sandostatin they started using in 2000, lanreotide in 2006, pegvismant in 2009. Because Claire and I and Lisa did our studies, we started using our pegvisomant, or Somavert as it's now called, as soon as we finished our study back in 2007. So we had 45 patients of our 193 on Somavert in addition to their sandostatin treatment together. And some of those, because they also have prolactinomas, are also on cabergoline.
So if that's the case, if you got samnostatin R and you're having Somavert, is it Somavert every day or just like once a week or?
Somavert is once a day before bedtime, an injection. 10, 20, or 30 milligrams. 30 is the maximum approved dose in Canada. And then again, there's sandostatin, depending on their growth hormone and IGF-1 level, are titrated either up or down accordingly. But we try and max them out on sandostatin first, and then start out slowly with the Somavert, and then gradually titrate them. So again, the problem with the unrecognized patients are no symptoms to their first complaint, then it's usually headaches, and then an increase in growth. So the growth starts when you're still in puberty and your long bones start growing. So that's how you end up with giants, which we have quite a few in our practice. And so the role of our healthcare professionals, the endocrinologist, internal medicine, neurosurgeons, neurologists, head and neck operations, nose, thyroids, carpal tunnel. I mean, you'd be surprised at the number of people that go for carpal tunnel surgery, and again, not being picked up that they're an acromegalic. And knee operations. Now, knees and hips we're seeing a lot more patients having knee and total hip replacements in these last 2 years. So back in 2005, they had low cure rates. They had only a 30% cure rate. Adrenal insufficiencies, there were 50% postoperatively. Endoscopic surgeons had a better cure rate with an experienced neurosurgeon. And radiosurgery, which is radiation treatments, which again in Canada we don't like to do anymore. When I first started doing this, it was surgery and radiation, and then sandostatin came out. Well, in our case, radiation therapy is their last resort. We want to do everything possible, even if it means sending the patient for a second or even third surgery to do more debulking of the growth before we'll consider radiation.
Is chemotherapy, he's been told radiation will be the last resort, so that's common.
Yeah.
That chemotherapy would actually be preferable to radiation.
Yeah, because
That's common?
that's common.
Okay.
And again, you're looking at the patient, the age of the patient, the kind of tumor they have had, and it won't just be one drug, it'll be a combination of drugs, because what's happened, there's a protocol. So on certain days of the week, you'll get certain meds, on other days of the week, and it's because of the whole cell cycling system. As the tumor breaks off, it kills it in different stages of the growth of the cells.
Is the worry of radiation that you're talking about where your pituitary is such a small space in the collateral, is that the
Well,
reason we don't do that?
years ago, that's why so many patients became what's called panhypopit. You ended up in total hormonal pituitary replacement because you had large beams coming from all areas, whereas now they can actually pinpoint smaller beams to a more densely area. Yeah. Okay, so now let's talk a little bit about AIP mutations. So in Europe, overall, they're 3.1 to 16% of the patients. In Turkey, there's a 6% of the familial acromegalic disease. And medications, again, they came later to Turkey than the rest of Europe and the rest of Canada. Finland. So they had 334 cases at 5 university hospital centers, and their basal growth hormone was 1.0. And their diagnosis was from 1980 to 1999 patients they looked at. And they did a lot of genetic studies in acromegalic disease. And just like in Canada, we have quality of life questionnaires that they go through. So some of their issues, I guess it comes later. So they had 100 cases. 72 cases, again, were in macroadenomas. 26 for prolactinomas. Cushing disease, they had 21 cases. And gonadotropes, 4 cases. 3 cases had reoperation. 5 cases had adjuvant radiotherapy. 16 were on medical therapy, and again, Europe doesn't use medical therapy first. And hormonal replacement, so being hypopit or pan-hypopit, they had 42 cases. And the Cushing groups had the worst comorbidities. So in the Finnish study, they had studied 4,924 cases. And when I talked about signs and symptoms, their acromegalic, number one thing they were reporting was decrease in sleeping. Discomfort was next at 82%. Sexual activity was 85% of the cases, and their only complaint about eating was 100% of cases. The Austrian acromegalic registry started just in 2014. So they've broken it up into different cities. And 607 patients had their onset of at least 6.5 years before they were officially diagnosed. So again, microadenomas, the small tumor, do better with surgery. Their intracellular and extracellular cases are almost evenly split. 89% of them had 89% had surgery, 79% had a single surgery, 10% had a second operation, and 6% of their patients had 3 to 5 surgeries. And their main signs and symptoms were hypertension and uncontrolled hypertension and diabetes and controlled diabetes. Okay, now I've got a question, which I already know the answer to. So does acromegalic cause cancer? So when you're thinking of acromegalic disease, you've got an increase in growth hormone, an increase in IGF-1. So here in Canada, we do see an increase in acromegalic patients. So when the doctor is doing that prostate exam that you guys hate, and they're feeling up your thyroid, and they're doing, they want you doing breast self-exams and colorectal and lung and hematology patients, there's a reason for it. It's because that excess growth hormone, if it's uncontrolled, can lead to these other cancers. And that's worldwide. That's a fact. So my takeaway message is, do those colonoscopies. I know you hate it, but the sooner if they find a polyp, get it out of there, because again, it'll be tested for cancer cells, and if there's no cancer cells, perfect. But if you can get that colon polyp removed, excellent. If you had a colonoscopy and they have found polyps, they want you doing colonoscopies at least every 1 to 2 years. If they come and your colon has been clear, then probably every 5 to 10 years, or is recommended by your own physicians. For males, that prostate exam should be done at least yearly, or if you have family history of prostate cancer, then do it more regularly. For women, breast self-exam every month if you're premenopausal. After age 50, you should be doing it. We've had patients who were 26 years old with breast cancer, with uncontrolled acromegalic disease, and their breast cancer was actually diagnosed first before someone picked up that they were an acromegalic. And they probably had their acromegalic disease since they were a teenager. Thyroid exams, we have a large population of thyroid cancer patients, because we also see a lot of thyroid cancers. And again, if you've got nodules in there, we want to get a neck exam and do neck ultrasounds, and if we have to do biopsies, we do them at our site as well.
So I have a question.
Mm-hmm.
My endocrinologist doesn't check my thyroid gland. Should I get an endocrinologist who is specialized in thyroid conditions?
I would say yes.
Yeah, because I have two endocrinologists. One of them looks after pituitary gland. The other looks after my metabolic bone disease. And so no one looks after my thyroid gland. So I was wondering, so do I need a third one?
And that's a scary thought. Why do you need to see 2 endocrinologists? They're all trained when they do their training for everything.
Sure.
But I know, in Toronto, we have our diabetic specialists, and that's all they do is metabolic disease and diabetes. And then you have ours, like Dr. Rezat, who does everything. But yeah, they should be, if they haven't felt anything in there,
He doesn't
then that's good.
care about I mean, he does the testing, but he doesn't actually do the physical exam.
Yeah, they should be doing it
Right.
with every checkup.
We can do it ourselves, what are we looking for?
You're looking for nodules.
Yeah.
So we have, yeah, so we have both thyroid nodules and parathyroid, because you've got your thyroid gland sits here, and you've got 4 parathyroid glands attached to your thyroid. So if you're looking for lumps or bumps or something that's abnormal, or if you're having difficulty swallowing, that would be another thing to check on.
So I would just research online or get a reference from another.
And your family doctor doesn't check it?
No.
I could put the information on the Facebook account about all the different ones. So, that there's information there to read up on.
Right, but my question is, how do I find the?
Usually it's usually your endocrinologist who's treating your acromegaly disease that usually looks after your thyroid as well. Because I'd say 80 to 90% of my patients are hypothyroid, so they're already on thyroid replacement. And one of the cases I have, I might not be able to get the slides up on it, but he came to us, he was a new patient, just diagnosed, well, let me rephrase that. He was diagnosed back in 2001. He was on the operating table with the neurosurgeon. The surgeon, in his highfalutin way, comes in and says, "You have a cold, I'm not doing you." Now, whether he had a cold or not, because acromegalics are prone to sinus infections, I don't know. But he was shuffled from hospital to hospital to hospital all over the GTA. I met him at the end of August to do his oral glucose tolerance test and his metabolic testing and everything. He had a tumor, a growth on his neck from his left ear to this side. Let me see. Probably half the size of a volleyball. And then when you turned his head, he had probably a grapefruit size on this side.
So that's soft tissue. Right?
Yeah, but because the minute I laid him flat to put his cannula in for his testing, he became hypoxic, so I immediately had to sit him up. That tumor is so big, it's compressing on his trachea, it's compressing on his lung. He can't hear out of one ear. His eyes are draining fluid because this thing is obviously draining everywhere. And so we couldn't get him into an MRI machine because he can't lay flat. So we sent him for a head and neck CT scan. So the CT scan, you lie flat, but they can move the bed up and down. So they managed to start at his head, go through. We could see his pituitary gland, it's huge. And then his neck, they went down to the upper part of his chest. One side is 13 by 6.5 by 10 centimeters. The other side is 10 centimeters by 6.5 by, I think, 8 centimeters. And those are the 2 largest nodules
In the
in his thyroid.
Yeah.
Yeah.
So how does that go undiagnosed for?
I can't explain it.
I had a thyroid tumor about this big when I was 26, and nothing. Like I had nothing, and then all of a sudden, one day, we noticed a lump. But oddly, I had a thyroidectomy, and the same endocrine who did that when I was 26 is now on his endocrine team for his acro.
Yeah.
Tom Baker in Calgary. They're not related in any way, my thyroid thing and his thing. But she's seeing him for acro, but she does all the thyroid stuff too. So
Yeah.
you should be able to say to your doctor, I want you to test
Yeah.
my thyroid.
Frankly, like, you gotta beg to be, your doctor's there to help you, so
Yeah.
tell your
Yeah.
endocrinologist, if he's not checking your thyroid, just tell him, hey, before I go, give me a thyroid physical.
Yeah.
It only takes like a minute to palpate it when they're looking for something.
So you look down the road and the cop's sitting there not doing anything, to yell at the cop isn't okay, but it's perfectly reasonable to tell him, hey, go help this person, go do your job. As long as you do it in a respectful fashion, it makes perfect sense.
The number of endocrinologists that see patients for diabetes probably amounts to 30% of our practice. And they do nothing for their acromegalic disease. Like, they clearly walk in, they've got the frontal bossing, they've got the long jaw, the bridge of their nose is flat, their cheekbones are spread. You can see on their rings that their fingers are quite swollen. Their shoe size has gone up 3, 4 sizes. I mean, that's not normal.
Yeah.
Even in puberty, I mean, you grow a little bit, then you fill out. You grow a little bit, then you fill out.
Yeah.
So when you see these other manifestations, it's absolutely ridiculous. So we're doing more research into genetics. So as I said, AIP, FIPA, we're doing a lot of studies on, again, because Canada won't pay for it. If the patient wants the test done, then they have to pay for it and get it done in England. So do your genetic testing. If you smoke, quit. You would feel the hypertension, the diabetes, the more things that you can get under control, the genetically modified food. If you eat whole grains, whole fruits, like green apples, you're going to get more nutritional value from it. All these things are adding all these toxins and everything into your system, which you don't need. So quit smoking, get regular exercise, and stay healthy. So here's a few take-home questions for you. And then, my slide from, I had a lovely picture, I guess not going to pop up, of we used to call it the Sky Dome and the CN Tower. Now they call it the Rogers Centre in Toronto. Yeah. So let me go back to this patient with these huge nodules on his thing. When we came to see him, Shireen was in clinic. I was doing this testing. Nicola was with me from Pfizer in observing me for the day. And we're trying to ask this patient questions. Well, he's an Italian male and he just wants to talk about his gardens and his food and everything else. He doesn't want to talk about himself. So I gave him a signs and symptoms sheet, which I developed years ago. And there were quite a few things checked off on it. Headaches, can't sleep. He obviously has problems chewing and swallowing because of these thyroid nodules on his that like almost the size of his skull. The arthritis, having problems with his gardening. He's poor exercise tolerance. He can't sleep flat. He has to sleep with his head of the bed almost in a 45 to 60 degree angle before he can sleep, and he doesn't sleep very well, obviously because he's got sleep apnea, and he, again, not on a CPAP machine. Back in 2013, he was diagnosed with diabetes, and the only medication anyone since 2001 has ever put him on was insulin and metformin. He's been to numerous hospitals in Toronto, Brampton, Oakville, Mississauga, Sunnybrook, and no one picked up or no one's followed up for his acromegalic disease other than the diabetes. So he's got so many issues going on with him right now. We started him on his first dose of Sandostatin that day, took him up to clinic, showed Shireen, I said, in all my years of nursing, I've never seen someone with masses that big, ever, in my entire practice. And I mean, I see a lot of unusual things. So we sat down with them and said, look, we have to get you on therapy today. We want you on 2 or 3 drugs, but we realize insurance is going to be a problem. We want you on, so I gave him his first dose of Sandostatin. We want him on Somavert, which we're trying to get funding for him because he doesn't have insurance. We want him on Acromegaly because, again, his prolactin level, it's elevated, not that much, but the more things we can do for him, the better. We've got him booked for a 2D echo, and while we're waiting for that, we did a chest x-ray, and he's got left ventricular disease, which means his heart is pumping so bad and so fast because of all this extra fluid that's in his system. He's having heart issues. But after that first dose of Sandostatin, he called me the next day and he said, Lori, I'm having diarrhea 9 or 10 times a day. That's not normal. I said, yeah, but Francesco, look at how much fluid you've got on board, not counting your neck, your hands, your face, your legs. You've got pitting edema in your legs. Your shoe sizes have grown 4 sizes in the last couple of years. Your body's getting rid of all that fluid. When we got the rest of his blood tests back, he was adrenal insufficient, so I brought him in for an ACTH stimulation test. And again, he said, somebody keeps calling me at home, and I wish they quit bugging me. And I said, it's the Access program trying to set up your second injection. So after his ACTH test, I gave him his second injection. And the swelling on his neck, I'd say, is decreased about a third. His eyes, because there's so much fluid in there, aren't tearing as much as they were because of the sheer volume of pressure that's on his neck. His hearing's improving a little bit. He's noticing his shoes are starting to get a little bit loose, because when we looked at his shoes, when I went to weigh him, he had a hard time taking his shoes off because his feet were so grossly swollen. He hasn't increased his shoe size. He could probably go up another 2 shoe sizes because his feet were just wedged into these running shoes. So I said, the Access program's calling you, trying to give you your injections. Well, Mom keeps hanging up on them because his mom only speaks Italian. And I said, well, the nurses do speak other languages. We can get you an Italian nurse to come in. So he finally got his 3rd injection just last week. He's booked. We've discussed him in rounds. We have clinic on Fridays for our thyroid and parathyroid patients. So our surgeon, head and neck surgeon, has already looked at the CT scans, and he said, oh yeah, you can't do the pituitary surgery. You got to get that neck thyroid taken care of first. So he's coming back in November. So I've already got him put in for his next blood work. So by then he'll be due for his 4th injection. So they should be able to, with the swelling already coming down, it'll be easier to do both of his surgeries. So he'll have to have his thyroid done first before we can even look at the pituitary gland.
So if you're losing hearing in your ear,
Because the tumor is that big, it's actually going, the fluid's actually going up around and occluding the your ear canal.
okay, so if you're having ear problems and you feel like it's like really far down and it's plugged and it's just, you can't hear anything, and then all of a sudden you get gushing water, and then after that you're getting blood out of your ear, right?
That's a lot of pressure.
You still can't hear anything, but you can't get an ENT to even pay attention to what you're saying because he doesn't understand the condition and says, your ear's fine, you gotta go. Like,
We've had patients do that, and they've ended up coming into Emerge, and they'll go through, and the Emerge physician will finally say, oh, there's a problem there. We need to get an urgent ENT consult, and they'll bring in a different physician, a different ENT person, and say, oh yeah, you need this, and this done.
yeah, because cleaning out your ear
Yeah.
and finding blood is not good.
That's not normal.
So is that from the acromegaly, like from the gland?
It shouldn't. No. No. Yes.
Did his tumors have anything to do with failure?
He does, well, that's what we're checking now, but when we did his thyroid blood work, he's not only is he hypothyroid, and again, no one's put him on thyroid medication, but when I did his thyroid globulin and antithyroid globulin, we actually think he's got a thyroid cancer, a papillary thyroid cancer in there as well. So again, that surgery is going to be done first to relieve the pressure. Then when the pressure is relieved, then we'll be able to put him into the MRI machine to get his MRI for the neurosurgeon. Because the neurosurgeon won't do pituitary surgery unless he's got an MRI on board.
So if you have tumors in your pituitary and your thyroid, is it more likely that you have, is that MEN1?
We do have a lot of MEN1 patients who have all these other different diseases, yeah. So again, we did blood work for that, for him as well. Yeah. Yes?
For patients with transfemoral surgery, do you deal with a lot of them complaining about dry noses?
Afterwards, yeah, because they've opened up both sides of your nasal passages. The tumor, and many times, if it's invading the cavernous sinus, it totally blocks off your sinuses, and that's why you're usually having a lot of sinus infections. So when everything gets opened up, everything is draining out of there. So just use some humidity, particularly at night in the wintertime, because you want to keep that moist in there.
Have sinus infection more dry, dry as opposed to infection, just dry that you see.
Yeah. Yes. Yeah. Yeah.
More so in the wintertime, actually, to be
Yeah.
quite honest, because everything's dry.
I have a condition wrong with the almost year round.
Yeah, because the air conditioning is pulling moisture out of the air as well. Yeah.
And the other thing is, when you talk about arthritis, is it when you say arthritis, it's just all over the body or just?
I probably have 50% that are having total hip and total knee replacements. I've had a few people with actually considering shoulder replacements as well. And again, because they were so long in being taken to be diagnosed, the guy with the shoulder problems, his arthritis is so bad. It's not only in his shoulders, his back, his spine, and his hips. So his rheumatologist trying to decide, well, which surgery do I do first? But until we got him controlled on his acromegalic disease, it wasn't feasible to go and do it until it was under control.
So once the growth hormone stabilizes, are you kind of think like with bone density?
We make sure we do bone densities both on our acromegalics and our growth hormone deficient patients, because again, it will show that a lot of acromegalics are vitamin D deficient, and that contributes to bone loss as well as the arthritis. So we would like to have a baseline bone density done.
Once the growth hormone is normalized, is there a fact that your bone density would drop?
Once it's normalized, then your bone density should be stabilized if you're on, if your hormone levels are low and you're on, if you need replacement therapy, if they're at therapeutic levels. So vitamin D, because most patients in Canada, let's put it that way, are vitamin D deficient, because most of them don't drink a lot of milk, and once they're replaced, as I said, we do baseline DEXA scans, and then if we need to, it will say if it's below average, then they recommend how frequently. I think we can only do it once every year, and in some patients once every 2 years to monitor them. Yeah, because again, we'll check their parathyroid disease, their calcium, their ionized calcium, their thyroids, their glucose, their hemoglobin A1C. And one thing I didn't mention, I would say at least 60% of my patients are either glucose intolerant or diabetic. Oops. Once their hormone levels have normalized, then something Jerry had mentioned about the IGF-1. IGF-1 is linked to fat mass. So if you've got a large abdominal fat mass, if you get that down, even 5 to 10 pounds, your IGF-1 level will start dropping. I've got a young guy. I think he just turned 43. He was probably about 80 pounds overweight. And I said, well, what are you doing? He's a computer tech guy. He's either working on computers, fixing computers all day long. So he's sitting. I said, do you go for walks at all? So I finally got him walking. Well, then one day after hearing Paula, who was our nurse, Paula decided she wanted to lose weight, and she'd just go and do triathlons. And God love her, she's still doing them.
Ironman.
Yeah, an Ironman. Martin decided he was going to do it. So he started with the 5K and then a 10K, and he's worked up to 25K. He keeps saying, Lori, I've got all this weight, like my pants, I can hold them out to here. I said, that's great. I said, how's your growth hormone? And he's looking at me. He said, well, you're the one that draws the blood. You should know. So I'll do his growth hormone and his IGF-1 level, and it's like, Martin, your levels are coming down. But we haven't done anything. I said, no, but you've lost weight because of your marathons. I said, you've probably lost 30 pounds. And he said, can I get off these treatments now? And I said, well, you keep losing some more weight, you get another 20, 30 pounds off. We might not have to do your injections every 2 or 3 weeks. I've got some patients who only come in every 8 weeks for their injections. When I got this new patient, Francesco, when I got his blood work back, he is diabetic. His glucoses were high. His growth hormone was greater than 40 throughout the entire test. He didn't suppress at all. His IGF-1 was 960, and a normal for his age group would be 200, 250. So it'll be interesting when he comes back to see me in November, how much it's come down. But it's important to know your numbers. Your glucose, your hemoglobin A1C, your thyroid, your calcium. One of the things I developed, a lot of patients were complaining of numbness and tingling in their fingers, and they're on Sandostatin. So we started doing vitamin B12 injections. the sandostatin was actually suppressing their vitamin B12. So 6 out of 193 patients I now have to give vitamin B12 injections to as I'm giving them their sandostatin injections as well. Most of those acromegalics are all vitamin D deficient or on replacement therapy. We've got a couple that are hyperparathyroid, so they've had, not only did they have to have thyroid surgery, they had to have their parathyroid, and it's the same surgeon. So when he's in there, he takes a very good look around and say, oh, by the way, I had to take it to parathyroid growths as well. So yeah, and something we started this May at our site, it's called the patient portal. We have electronic patient charts, like patient EPR, electronic patient records. So when we started the patient portal, the patient goes in, we give them an access code, they can actually see their blood work, they can see their pathology reports, they can see their medical doctor and surgical reports. So they can follow along and say, oh, okay, I've got a little blip here. And it's like, well, what were you doing that day that suddenly all your results have suddenly gone up? Well, I missed my injections and I wasn't eating too great and I stopped walking and somebody else is walking the dog. And I said, okay, fine. Go back to what you used to do. And then about 4 weeks later, we'll check. And then, of course, everything came back. He'd been normal and come back down into normal range. So know your numbers. And you're your best advocate. You know what your body does. You know what it normally does. You know if you're feeling crappy. And for our patients, I'd say both equally, men and women have problems with the sweating and the shaking. And it's check your ACTH and your cortisol levels. You're probably adrenal insufficient as well. Because if you're feeling tired all the time and you're like having these shakes and stuff, your adrenal glands are your fight or flight hormones. So if they're not kicking in enough when you're under a stressful situation and you're sitting there shaking, it's probably because your cortisol has dropped into its boots.
And you cannot do the blood cortisol test. It won't work for acromegaly. You have to use 24-hour urine test.
It's called a 24-hour urine-free cortisol.
Yeah.
You can measure cortisol, but if you're on prednisone, you're not going to get an accurate result. And prednisone long-term use, whether it be for arthritis, whether it be for infections, because many doctors put you on prednisone when you've got a really bad chest infection or pneumonia. Chemotherapy, prednisone's used. If you've got asthma, there's probably prednisone or some kind of glucocorticoid in your puffer. Again, it's a steroid, can all contribute to diabetes.
Is there any questions you'd like to ask us? Because we're kind of a little bit past our time zone here.
I have one question.
Sure.
It's, something that's totally not related to any of all of this. But I know that a lot of acromegaly people have enlarged tongues.
Mm-hmm.
And one of my surgeries, when I had half my thyroid removed, the anesthetist was a very new anesthetist, and she wanted me to be awake for the intubation. And no matter how much she tried to freeze my throat, she couldn't get it down without any with it frozen. It just wasn't
Yeah.
coming down while I was awake. I'm sorry, I got a tickle.
Were you on therapy at that time?
I had been on sandostatin.
Okay. Because the enlarged tongue and the swollen tongue and the throat, once you usually start on treatment, it starts to decrease it a bit and it makes it easier. So when
Even after the surgery of removing the tumor, my tongue is still very large. It hasn't.
okay.
So my fear here is if I have to have more surgery, I managed to get an anesthetist to do that when I did my
Transphenoidal?
He was able to do it with, well, you're semi-conscious going under.
Mm-hmm.
But my fear is that I'll end up having to be intubated and having to be awake for any future surgery, and that scares me more than anything because it's just not a pleasant thing.
Do you wear a medical alert bracelet? You should be. Everybody should have a medical alert bracelet. And the other thing that they can put on that record is the anesthetist and the size gauge of intubation tube they used. Because everything's bigger. It's harder to get blood work because your skin's thicker. I mean, I've had patients, their skin was like putting it through a shoe leather needle. The walls of your veins are thicker. Your tongue's swollen. Your esophagus is swollen. And in Francesco's case, when we looked at his CT scans, they said, oh yeah, we're definitely going to have problems with him getting intubation. We've tried to find an MRI where he can sit, which we've yet to find in Canada. But as I said, the sandostatin is helping to actually shrink the swelling. So we usually give anywhere between 4 to 6 months of treatment before we send them to the neurosurgeon. We'll still consult the neurosurgeon, but again, he's got a long waiting list.
So I'm not alone in this where it's
No.
a difficult procedure for
No.
an anesthetist
Yeah.
to get you intubated.
Yeah.
And I think that, you know, when you're going into any kind of surgery, you're already frightened for what they're
Mm-hmm.
going to do. But having to be awake for it is just, was just even more scary.
Yeah. Yeah. And there's no reason why you can't say, I want a little bit of sedation before you start putting these things in. There's no reason. I mean, a lot of our patients are so claustrophobic when they go to do their MRIs. We have to sedate them before. We give them Ativan pills to take before and during in order to get them through the MRI machine.
Well, but the one thing that happened was that the
Anesthetist?
yeah, no, the doctor, the throat doctor, he said, hey, he just said, give her the medication, I'll intubate her. He said, what kind of an ENT would I be if I can't,
Yes.
intubate my patients?
Yes.
And he told me that after, and I was just so grateful because it was just not going to go down with me awake.
Yeah. And again, that's why a lot of these patients are referred to our large treatment centers, is because you're dealing with the experts in the field. You don't want somebody in your little small town, and we've had people in other towns do their surgery and wonder why, well, their growth hormone's still 29 post-op. Well, it should be less than 4 post-op, immediately post-op, not still 29. He's still got active disease. So again, the better your surgeon, the better your endocrinologist, the more you guys can educate yourself. So I've included lots of articles, journal articles in here for you in my presentation, because it's only going to help you in the long term. And the same going back. There was a booklet we produced, and Pfizer's actually helping us. The Canadian Acromegaly nurses we put together a couple years ago, and Pfizer's actually producing it for us. Give them to your family doctor, give them to your dentist, and get them to read up. I mean, I've got patients that they might be their first case, but then since then in the years gone by, they're no longer their first case. Their dentist might be seeing 4 or 5 acromegalics. Their ophthalmologist might be seeing 4 or 5. So the more we can educate, and we're trying to work on a Canada Worldwide Education Day with our poster presentations and things. And the app is just coming out that we started working on. We discussed it earlier in June to get more people, more knowledge. And the more knowledgeable that you guys are, the easier it's going to make for the next person coming along. Because I mean,
I just, that was just a question that's always been with me, and I just thought it was rather strange that an anesthetist would have trouble intubating somebody. You know, normally you would think it would be a problem.
I mean, it's what they do day in and day out. Yeah. But again, you're probably his first acromegaly patient he's had to do intubate.
She.
Oh, she. Okay.
Did you put these all together?
I did.
Except for these ones here?
Yeah, those are the only ones. Yeah. Back in, okay. I'd say back in 2000 when the whole Creever Quarry closed all the hospitals, and they closed, well, even before 2000, because that's when we closed the wells, they closed all the endocrine testing centers. It became harder and harder for people to get diagnosis, to do dynamic testing, which is part of what I do, is all the glucose tolerance test and insulin tolerance tests that you said you had earlier. Again, the insulin tolerance test, you're looking at your cortisol levels, again, because if you're adrenal insufficient. So in our practice, we probably have 80 to 90% are on thyroid replacement, probably another at least 60% on cortisol replacement. And again, use Cortef or Cortef acetate rather than prednisone, because then you can get an accurate cortisol level as well as the urinary free cortisol. And we have a large number on either estrogen or testosterone replacements as well. Yes.
I just have a question, and I don't know if you know it or, he has no pituitary gland left, so now they've just prescribed testosterone. That is not gonna be covered, ever.
Which is,
By Alberta, it will not be covered, not with special authorization, not with nothing.
for what?
Testosterone.
But is it not necessary for him?
Yes, it is. It's necessary for his bone growth
So it's not.
and his bone density.
He has 2 drug plans, it's not gonna be covered. And I said, can we get one of those letters, because we have to get a letter for convertible.
So write to the Ministry of Health and with your documentation, and they'll ask for, has he done an oral GDT? Has he done an insulin tolerance test? And all these tests, as all of them. I mean, we've spent a fair amount of time getting these drugs covered in Ontario. And when,
There's a way around it.
yes, you
If it's
just,
gonna be something you're gonna be on, because if you're only gonna be on it for like a year, you can suck up that cost. But if you're gonna be on something like that for the rest of your
life,
life,
I've
these are
been
big
on it
deals.
forever.
yeah.
Where do you live?
I live here,
Do they cover it?
you know.
Different provinces.
Different
have
province.
different coverages.
So,
You might have to move, honey.
I first had the shots, and then I had gels,
were you guys on?
patches, and now it's gels.
But it is covered.
Covered.
Have you seen, I'm gonna
And the injections last longer and work better than, there's sprays, there's all kinds of stuff you can get on the internet. Yeah, the androgel, yeah. Yeah, and a lot of times they came out, one of the reasons they came out with the gel was because people were terrified of needles.
It's not that worse, better or worse, and people are scared of needles.
Yeah,
For me, I had an allergic reaction to the shots. Whatever the carrier shot was, I had allergic reaction to it.
yeah,
You know, the first
Yeah.
time it's a little bump, next time it's worse, and it gets worse the next time, so
yeah.
So sorry, what do you use now, the gel or?
I used the gel. is
The
what
gel.
they've given me.
So we just haven't started it yet because he had no coverage for it. So we're
Just
still-
get them to keep fighting and send it off to the Ministry of Health.
Deal, right?
Yep, yep. Because again, you're not the only person that's probably having the same issue.
Give them a hard time, love it.
Yeah, I mean, we do it all the time.
So, it is, do you know if Somatuline is covered in Toronto?
If you're under 65, you have to apply for Trillium, which is our Ontario drug benefit coverage. But through our access program, they help us get reimbursement coverage.
So, I'm on Somatuline now, and if I relocate to Toronto, can they mail it there? Or,
No, you have
No.
to get it from the province you're in. BC's not gonna send it to Ontario.
right,
I mean, if you guys have been kind of on Twitter and that, there's a lot going on about, becoming one. The whole of Canada.
Yeah.
And it's just not, it's been put out there that we all kind of go on one umbrella, all of Canada for medications. And they are trying to work on it, but I think it's gonna be a while.
Yeah. I mean, on Ontario and Quebec, we fought long and hard to get a lot of these on formularies and get them covered either through private insurance or their provincial health programs.
But
So it's, in that sense, it's helped the smaller provinces who don't have many patients, because we do have large volumes of patients in Ontario and Quebec. It's helped the smaller patients push forward the same information that we've got these patients here in our provinces too.
so, who do I ask, about this, my endocrinologist,
You're-
the
you-
access program?
They
Not
have,
the access program, the relief, I guess.
yeah, they have to either write a letter to Trillium or whichever your provincial health program is. Yeah.
But the pharmaceutical companies do offer help. If you're struggling and you just don't have that extra medical plan, or, like, you're just in hard times and broke, like right now, I'm stepping down from work, because I can't do it no more, I'm done. I can't pump the floor for 9 hours anymore and take care of my residents.
I mean, I've got a McEwen Albright patient who's a giant in Toronto, and a lot of his medication, he's a Mennonite, so he's got no insurance whatsoever. So we've got them on, he's got on compassionate therapy for his treatments.
They're
Right, so
there
he
to
has
help,
gigantism
right?
and looking right?
Yeah,
Okay, and he got on a compassionate.
yeah,
program
because
for
we started with the drug studies for the sandostatin trials and the Somavert trials, and we got him in that way.
So he's on Somavert, okay, but he's the only patient that you have with.
No, we have several patients that are on compassionate therapies.
Okay. And how old is he, sorry?
I don't think he's reached 30 yet. So but he'd been on it, well, since 2006, 2007.
Right, yeah. That's good.
Yeah.
This group has been really good that you've done, because I know we didn't know how to do things. And by talking to other people, somebody in Manitoba said, try it this way, or try it this way. And for a new person coming in, I didn't know where to look.
It's a lot of,
So-
a lot of information
That's
you
right,
can
I'm not-
download
we're
very
not-
fast.
So you're-
I can help you with
You're
that,
in
but-
Alberta?
Yes.
I am, but through the group, I kind of learned, well, try this, or call this group, or ask this group, and it just gave me a direction to go, because I was kind of scrambling.
Dr. Constance Chick in Edmonton. If your physician refers her to you, she might have some help for you.
It's a great group that you've done, so I
Yeah.
appreciate it.
And I'm telling you, if